Hello everyone, dear learners. I think we have now 5 participants, and that's a good start. And as you know, this is Dr. El-Abedin, a lecturer of Ophthalmology, Manufia University Hospital from Egypt. Also, I'm a former fellow of Pediatric Ophthalmology and Adult Strabismus at Stein Eye Institute, Los Angeles. So I'm saying this because I already dealing with patients with amblyopia, so I shall add my experience regarding this topic. And as you know, also I'm one of the faculty staff of Motosami Virtual University of Postgraduate Ophthalmology, and this is another lecture regarding the course for candidates who will appear for the final FRCS exam. And I have created a list for my previous lecture. You can find it on the YouTube channel. Thank you for attending the meetings. I'm happy to see you again. I've chosen this topic because it was written in your list. Although I don't expect that you will be asked about the amblyopia in the final FRCS exam, it could be a part in your answer. So like in the Viva station, if you are given a picture of congenital cataract or congenital glaucoma, for example, part of your answer is to mention the treatment of amblyopia. Here I posted this slide yesterday, I believe, so this is a kind of notice, so bear with me and be patient because sometimes I may go off topic apparently, but I like to mention some study advice or to correlate our topic with other topics in the ophthalmology. Because I appeared to many exams and I'm an examiner, national examiner, so I want to help you. And whenever there is something related to strabismus, I have the tendency to speak a lot. Here I mention tutorial instead of lecture or presentation because I want you to interact more than previously. To be honest, I am not an expert, and I don't know exactly how I can design a tutorial in virtual meeting, but I tried to incorporate more questions here, so I want to listen to your answers and to listen to your voice more than you listen to my voice. It has some disadvantages, like it needs time, but the advantages outweigh the disadvantages, because it helps you to build your confidence, and it's like a mock exam, and it's highly effective if you participate in the discussion. We will see. Before getting into the topic, why it is important. So here is the first question in the presentation. I want you to fill in the gap at the first sentence here. Space is responsible for more cases of childhood onset unilateral decreased vision than any other causes combined. Okay, you mentioned refractive error, but be attentive to some key words here. Here the sentences is talking about unilateral. So Dr. Kirsana, if you are dealing with pediatric cataract, you may think that pediatric cataract is the most common. So Dr. Hala rephrase refractive error into Isotropia. It's close to the correct answer. We will see. And how about the second sentence here? Is the most common cause of unilateral visual impairment in adults younger than 60 years. Dr. Sana, cataract. So cataract is, I believe it should be bilateral, and it should be older than 50 years. So another keyword here, unilateral. Let's make it more clear. So that is the most common unilateral, and in children it could be reversible, but in adults it is permanent visual loss. So just remember that we are talking today about amblyopia. So the correct answer here is amblyopia, and these two sentences were taken from the American Academy Pediatric section. since the amblyopia is the most common cause for unilateral impairment in adults, this means that there is a lack in the screening programs, because amblyopia is easily to be diagnosed, but the problem lies in the screening for early detection and timely treatment. And that's why it's important. So the goal of this presentation is to screen for amblyopia in order to avoid missed the diagnosis. And we will see later that we have, on the other hand, don't rush for diagnosing amblyopia. You have to exclude any organic lesion. And the second goal here is to properly and early treat the amblyopia, because in the early stages it could be reversible and it could be treatable. All right. So I think nobody mentioned amblyopia as the answer, but we'll see that the most common form of amblyopia is due to refractive error. So that's why I said it is almost correct. From exam standpoint, this is one of the commonly asked questions in national exams. So personally, this was my first question. I was asked this question in the Viva station during my master's degree, and it was the first postgraduate ophthalmic exam. And despite the fact that I already know what is the amblyopia is, I wasn't able to give the examiner a well-articulate or eloquent answer. And I started to jump into the classifications and the etiological factors. So in short, I gave him a dusty answer. And actually, unfortunately, it was the first answer. What's the problem of stumbling or stalling at the first answer or the first question? Because if you don't answer the first question properly, your confidence goes down and your stress goes up, and this may have a detrimental effect on the following questions, and it may have a negative impression of the examiner upon you. So when it comes to definition, you have to memorize what's written in your book. There is no time to invent your own thoughts and translate your thoughts into words at the moment of the exam. And I remember one of my seniors told me once that the first important thing to learn by memorization is a definition. So whenever you have a definition, you have to say it properly, even if you think that you know it well. Like what is the definition of visual acuity, for example? We already know what is visual acuity is, but to give a definition, it seems hard unless you prepared beforehand. And even if you check Kanski, you will not find the heading for definition. It's written here behind this tape in 2 or 3 sentences, but the absence of heading for definition may confuse the student and let the learner to jump into the classifications or the etiology without paying much attention to study or to memorize the definition word by word. Okay? And this is the goal of this presentation. So I hope by the end of this presentation you will be able to define the amblyopia fully and properly. What's the level of my presentation? It's in the middle. I want to be sure that we are competent when we are talking about the amblyopia or when we are managing cases of amblyopia. Of course, you are not novice or advanced beginner, and if you are a pediatric ophthalmologist, you have to add more information and to extend your knowledge on the topic and do your research. And the funny part here, if you are an amblyopia researcher, actually you don't need to listen to this presentation, except if you want to have some fun. Here is my references. I like to start mentioning my references instead of mentioning at the end, because in addition to the Kanski, our general ophthalmic book, we have to check our specific sources, and one of these is the Amblyopia Preferred Practice Patterns Guidelines provided by the American Academy. So remember this abbreviation PPP, because we will say it in the next parts more often. And when it comes to medicine, you have to do your research and literature check to proper manage your patient, but don't ignore your mentor advice, your senior's advice, because they have a longer experience than you. And sometimes we need to tailor the line of treatments according to the patient's value, according to the area you are practicing. So you don't need to underrate or underestimate the value of each. The value of the literature and the clinical trials and the studies, and also the value of your expertise or your senior's expertise. And above all, we have to consider the divine factors in order to provide, hopefully, the cure to our patients. Okay. I divided my topic into 3 parts, as I posted before. The first part today about the definition, mainly about the definition, and we will have an overview about the etiological factors. Then second part, we will continue or add details about the etiology. We will dive deeply in the etiological factors, and then mention the diagnosis, and again an overview about the treatment lines. The third part will be focusing about the treatment lines. So stay tuned. So here's today's presentation. This is a time frame. I hope I keep it on as planned. So the first 30 minutes about the definition, followed by the etiology, and of course we have an overtime, because I will wait for your answers. Before getting into the definition, which is an abnormal disorder, you have to know the normal. So this is a basic rule in medicine. Before you start knowing the abnormal, you have to have an overview about the normal, or like a background about the normal. The next question here regarding the normal visual development. True or false? At birth, visual acuity is poor. So I have the tendency to provide you with correct sentences, because sometimes wrong sentences contaminate your thoughts and remains inside your mind. So actually this is a true sentences. At birth, visual acuity is poor in the range of hand motions to count fingers. And don't ask me how they discovered this. But what is the cause? Because of the immaturity of the visual centers in the brain responsible for vision processing, right? And we have to keep in mind that we need 3 factors. We need clear in focus image on each retina, equal retinal images in both eyes, and normal ocular alignment in order for normal development of binocularity and normal development of vision, and normal development of visual centers, mainly the striate cortex, visual cortex, and lateral geniculate nucleus. Because after birth, the development continues. There is some form of refinement in the form of growth and dropouts. So we need, remember these 3 factors here: clear in focus, equal images, and normal ocular alignment. Regarding this graph, there is something called the critical period in visual development. The first stage is fast, where there is marked and exponential improvement in the visual acuity in the first 3 months, and then the curves slow down up to 7 to 8 years. So this is a vulnerable period here called the critical period, where there is some vulnerability or plasticity in the visual system, and any insult must be treated early. So any abnormal visual stimulation, if not treated, will result in permanent damage to these visual centers. And that's why we need to screen. We need to provide early treatment of any pediatric eye disorders in order to promote visual developments. So I put here the macaque monkey photo because some of the amblyopia studies were conducted on monkeys. The next question here regarding the normal refractive state: true or false? At birth, hyperopia values between 0.5 to +4 are considered to be within physiological refraction. Correct. So it's true. Of course, if you are pediatric, again, there are a lot to know about normal refractive state development and normal visual development after birth. But at the moment, we will stop at this knowledge that hyperopia is the normal refractive state at birth. And it could be moderate up to +4. Getting into the definition of amblyopia. Sometimes we like to start our defining any abnormality by mentioning the origin or the roots of this word. And there is a science regarding knowing the origin of each word. Do you know what is this science called? It's called etymology. So amblyopia is it comes from Greek and it means dull vision. So amblos, ambly is the prefix here means blunt or dull, and opia, the suffix here, means vision or sight. So the origin is dull vision. So if you have time in the exam, so if you imagine that you have a lot of time in national exam, written or viva, you can start defining the amblyopia by mentioning the etymology. But this is optional and not necessary. We usually, when we define the amblyopia, we mention the laterality. So here is a single best answer question, MCQ question. Amblyopia is unilateral, bilateral, uni or bi, or something else. So whenever you see something else, it would be the fourth option. If you say unilateral, it's not a bad answer because we used when we were undergraduate students, they taught us that amblyopia is a unilateral disorder. Later on, we discovered that amblyopia could be bilateral. So what is the most precise answer here is amblyopia is unilateral or less often bilateral. So adding this adverb of frequency show you your knowledge, knowledge about the incidence, which is more common. Is it unilateral or bilateral? It's kind of improve your way of answering. So you mentioned the incidence. It is unilateral, less often bilateral. So here I am going off topic for a while. So whenever you come across a disorder, you have to mention the laterality. This is important, especially in advanced ICO exams. Sometimes there is a fill in the gaps questions, and you have to choose unilateral, bilateral, or both, or could be either. So don't forget to pay attention to the laterality. So according to the laterality, you can answer with me. We can divide any disorder into unilateral or bilateral. Is there something else? It could be both. And whenever you have both, you have to mention which is more common, which is the typical. Is it unilateral is commoner than bilateral, or equals, or the opposite? And when it is bilateral, it is symmetrical or asymmetrical. And if it is bilateral, it is simultaneous presentation, or it could be sequential, like in an optic neuropathy, non-orthotic optic neuropathy. It is sequential. And also you have to mention that there is something called masked. What does mean masked? Means that it is bilateral, but it appears like unilateral. If there is a marked asymmetry, you may think it is a unilateral disorder, but actually it is bilateral, like in superior oblique palsy, like in ptosis. If you have moderate ptosis or severe ptosis in one side and mild ptosis in the other side, you may think it is unilateral. And we will find that it was bilateral after correcting the first advanced ptosis first. So masked or hidden. And there is something called trilateral. Do you know what is trilateral? So it's mentioned once in ophthalmology. And this is a common question to be asked actually. what does trilateral? So trilateral mentioned once in the ophthalmology. Do you remember where? It's again, it's in the pediatric. Retinoblastoma, so in congenital hereditary retinoblastoma, there is a bilateral, and so you have to elaborate more, Dr. Kirsana, on your answer. So sometimes too concise answer is against you, because you will let the examiner to ask you again, add more details. So there is a loss of some minutes here, and especially if the exam is time bound and you have a limited time to answer. So not osteosarcoma, something else. No, bilateral retinoblastoma, and what is the third part? It's benyloblastoma, all right, not osteosarcoma, Dr. Navid. So back again to amblyopia. So amblyopia, it could be unilateral, it could be bilateral, and when it comes to bilateral, it could be symmetrical or asymmetrical. And even there is some research about that even in unilateral amblyopia, the normal fellow eye has some sort of subnormal function, visual function, not in the visual acuity but other visual function. So the first sentence is here regarding the definition of amblyopia. It is unilateral or less often bilateral. Here, reduction of. So you have to continue these sentences. Can you continue these sentences, please? And this is the key word here in the definition of amblyopia, which actually originates from its etymology. Reduction of what? Reduction of visual acuity. Thanks, Dr. Navid. So we have a better answer here, Dr. Kirsana, best corrected visual acuity. We care about the best corrected visual acuity because vision is not a specific word, but you can, because if you have uncorrected visual acuity, but once you put the refractive error, for example, and you got 6/6 vision, so this is not an amblyopia. So it's better to say reduction of the best corrected visual acuity. All right. And actually, this is not only the visual function that will be reduced, but also if you check the contrast sensitivity and accommodation and also the binocularity, usually they are subnormal. Here is pop-up questions. Best corrected visual acuity, there is another abbreviation for best corrected visual acuity. Do you know the other abbreviation for best corrected visual acuity? You may find it in some research papers. What is the other abbreviation for best corrected visual acuity? Again, it's something Latin. So C, so double C, and this is the pronunciation. Let's see here.
Con correction.
So if you're interested in Latin, so you may find CC for the best corrected visual acuity, and unaided visual acuity or uncorrected visual acuity is abbreviated sometimes as SC. And here is the pronunciation.
Cine correction.
And I think if you are reading a lot of papers, you may find this abbreviation as well. So back again to the definition. So amblyopia is unilateral or less often bilateral reduction of the best corrected visual acuity. Actually, this is incomplete sentence. What is the to fully complete this sentence? That usually occurs in the setting of an otherwise normal eye. Or you may find in some references that occurs in the setting or in absence of organic lesion. And actually this is a confusing sentence for many, including me, because when we come to the etiological factor, you will find abnormalities like congenital cataract, for example. So how can we say a normal eye and we already have a cause like congenital cataract? And actually this definition, I brought this definition from the PPP, from American Academy Guidelines. And to further explain this confusing sentences, this is a better sentences actually. that patients with amblyopia experience a reduction in visual acuity that not or that cannot be attributed only to the effect of structural abnormality. It's a long sentence, but it's better and it's much more clearer. So in other words, you have a congenital cataract, so you clear the media, you provide the patient with visual rehabilitation, and still the visual acuity is not, the best corrected visual acuity is not 6.6. So here we can say this is a form of amblyopia. So despite the fact there is now normal eye, or like you provide the patient with the best refractive correction, you have a corrected treatment, you still have subnormal visual acuity. Then in the preferred practice pattern guidelines, another sentences that contradict the previous one in black here, that less commonly there is an abnormality on the eye or visual pathway. And that's why it was written here usually. But I want to show you that there is some confusion here in the definition, and that's why many students or many learners don't properly define the amblyopia, because every reference defines amblyopia differently. Another sentence related to the definition of amblyopia, and this is a very important one, and you have to mention it in your definition, that it is this is a diagnosis of childhood during the critical period. So this is a developmental disorder that results from abnormal processing of visual images, which leads to reduced visual acuity. So you have to mention in your definition that the insult here is early in life. So it is a diagnosis in childhood, or you can diagnose amblyopia in adult if they have a past history of etiological factor for amblyopia, and you have reduced visual acuity, best corrected visual acuity, and we have no structural abnormality correlate with this reduced visual acuity. So here is my numeration, like points that I tried to compile here in 10 points actually. So when you are defining amblyopia, you may start by etymology, but this is optional, that's why I wrote it in gray. And it's important to mention the laterality as well. And the key word here is reduction or decrease in the best corrected visual acuity. In some reference you will find the word vision loss. Personally, I don't like vision loss because in my mind vision loss means no PL, but as you know, vision loss means diminution of vision. It could be partial, it could be complete, and actually this could be the symptoms and this could be the sign. And a reduction of what? The most important aspect here is vision or best corrected visual acuity, but you can add there is also subnormal binocular vision or stereopsis, and also subnormal contrast and accommodation. You can mention no organic lesion, but you can add by explaining that it cannot attributed only to this abnormality, and it is something early in life. The second point here, you can give a hint about the pathophysiology, because it is abnormal in the processing of visual stimulation during the critical period of visual development. And we can't ignore the recent research, or not recent, the documented structural abnormalities in the visual cortex and lateral geniculate body, so you have to add some about the pathology. And you can add that it is reversible if it is treated early, because later on, after the passing of the critical period, it is the changes are permanent and irreversible. And again, you can mention that it is the most common cause of visual impairment in childhood, and you end your definition by mentioning some of the etiology. You have to mention the etiology. So here we start by A and we end this by A. So the definition is a little bit big, and you have to practice saying it and memorize it. So we have to articulate all these points into a form of paragraph, and I believe that that one in the pediatric section of the American Academy is the best definition. It's full, it's complete, it covers all the main points. So I want one of you, let's see here, Dr. Kirsana, to read the first sentences.
Ma'am, you want me to
Yes, just read it
read what is
loudly.
okay? Yeah. So amblyopia is a unilateral or less commonly bilateral reduction of best corrected visual acuity that cannot be attributed directly to the effect of any structural abnormality of the eye or visual pathways.
Excellent. So can you point out the key points in this sentence?
Ma'am,
Keywords.
according to like according to your previous the way of framing, first it was like unilateral or bilateral.
So this is the
You're just saying
laterality.
that laterality with the best corrected visual acuity is another thing, and the structural abnormality of the eye and the visual pathway.
Excellent. So here, Dr. Hala, please, can you read the second sentence, please? So if Dr. Hala is not available, Dr. Naveed, can you read it loudly?
Okay, ma'am. It signifies a failure of normal neuronal development in the immature visual system and is caused by abnormal visual experience early in life, resulting from strabismus, refractive error, or visual deprivation.
So here we have two key words here, or like key information. Can you point them out?
This normal neuronal development.
Yes, it is a developmental abnormalities in early
Right.
in life, and the second key information here.
Immature visual system.
Yeah, there's the
Yeah.
same meaning for early. Here, there is a mention. There is mention of the etiology here: strabismus, refractive error.
Strabismus.
Yes.
Right.
So
Visual deprivation.
you can mention some of the etiology in the definition. Okay, thank you, Dr.
Okay.
Naveed. Dr. Sana, please, can you read the next one?
Hello. Yes, ma'am.
Yes.
It is responsible for more cases of childhood onset unilateral decreased vision than all other causes combined.
And that's why it's important, right?
Yes.
So here you have to say unilateral. So because if you
Yes.
omit this word, it could be other there is some other causes for bilateral. So you have to pay attention that amblyopia is the most common cause for unilateral. Thank you.
Okay, ma'am. Okay.
So Dr. Vijaya, can you please read the last one? I know you are. I know you are a senior, but you can read it, please.
Yeah, sure. Yeah. Amblyopia vision loss is preventable or reversible with timely detection and intervention.
Thank you, ma'am. Thank you. So as you see here, the definition is like a big one, and you have to read it a lot and practice your study partner. And I bet you to ask this question to one of your colleagues tomorrow, so you can ask them, can you define amblyopia? It's easy, but it's difficult to articulate. But you have to cover the keywords here. All right. To summarize again our keywords, let's see this question: which one of the following fulfills the definition of amblyopia? This is a single best answer question, MCQ. We have 4 choices. So in single best answer, there might be more than seemingly correct answer, but you have to choose the best one. Thank you. I think all of you got it right. Let's read it together here. The first one, despite he is old, but he already has a past history, points to the amblyopia. You can diagnose amblyopia in an adult, but you have to exclude, of course, any other pathology. And here he has a past history of squint surgery, OD, and this might explain why his vision, despite perfect cataract extraction and perfect refraction, he still his vision best corrected visual acuity is 6.6. I shall add the best corrected visual acuity here. Regarding B, there was a mention about the uncorrected visual acuity, SC. But if suppose you put -3 and the vision is 6.6, so this is not an amblyopia. Especially if the onset of amblyopia is after the critical development, after the vision is fully developed. The next choice, C, cross-fixation esotropia. So cross-fixation esotropia is a kind of alternating. We will see in a minute that it has some risk for amblyopia, but not as unilateral manifest strabismus in one eye. The last one here, we have already an organic lesion. There may be super added amblyopia like refractive error or of course congenital disc anomalies. If we imagine that we have a magic treatment for congenital disc anomalies, but after 6 years, for example, yet the best corrected visual acuity wouldn't be 6.6 because during the early life congenital disc anomalies, of course, there is some added factor of amblyopia as well. So generally, we have already cause for diminution of vision. So the best answer here is the choice A. I used to mention the notation in meters, 660, but of course you have to know 660 equals to 20 over 2000 in feet, or logmar +1. Currently we are using decimal notation, so 660 equals 0.1. So how about cross fixation that I posted yesterday? This is a little hint about the strabismus here. So those kids with infantile esotropia, early onset esotropia, if there is a target on the right side, they prefer to visualize it by the contralateral eye. So if there is a target on the right side, they use the left eye to visualize this, to fixate on this target. And that's why the name cross fixation, because it's crossed, because it's a target on the right side and the fixating eye is the left eye. And here, if the target is on the left side, they are using the right eye to fixate on this target. And this could be the fixating eye, the left eye here. This could be the right eye here. So there is some sort of alternation, and this is good from the risk for amblyopia. There is a little risk for development of amblyopia, but it could be there. We have to continue our workup, our assessment. The most important point here, if we are checking the version, which means testing the ocular motilities of both eyes open, when we put the target on the right side, because this child is using this eye, apparently you may think that there is limited abduction of that eye. So it gives us a pseudo limited abduction. And again, if you put the target here, because they are using the right eye, apparently it looks like a pseudo limited abduction of the left eye. So how to differentiate or to check if it is a pseudo or a true limited abduction? This is a question for you. you know, when you are dealing with kids, they are moving their eyes a lot. So sometimes they look to the right side. So imagine in this part of this image, imagine the kid is looking to the right side, but you don't know that they are looking to the right side. You may think this is the normal eye, the fixating eye, and this is the esotropic eye, but actually they are looking to the right side, so this is the normal alignment here, because this is fixating on the target, and this is the actually the esotropic eye, because this child is not looking up in the primary position. He is looking to the right side. So how do exclude that this is actually a pseudo and not true limited abduction on that eye? Suppose you are testing now the right gaze. The other term for right gaze is dextroversion. Dextro means to the right, and version means you are testing both eyes are open. So in dextroversion, because this child is using the left eye, apparently this eye looks like not moving, like limited abduction. So how to demonstrate the abduction of this eye? How can we demonstrate abduction in this eye? So you have to force this eye to be the fixating eye by covering the other eye. So you cover the left eye. Yes, this is called duction. Excellent, Dr. Christina. This is called duction, testing each eye monocularly. So you have to patch the other eye. Sometimes you need to patch the other eye for half an hour or even more, because this child used it to cross-fixate. So you patch the other eye and in attempt to force the patient to fixate by the right side, by the right eye, so to demonstrate the abduction. And this is an important question, by the way. You have to know the differential diagnosis of limited abduction, or like we can say esotropia with limited abduction, because some of the causes are actually pseudo, like this one. And again, this is the I made this diagram to illustrate the optical component here. So in this part, in this right dextroversion, actually the left eye is considered the fixating eye, the normal aligned eye, because here the fovea is pointed to the target of fixation, and here the right eye is considered as the esotropic eye, because so it is the esotropic eye, despite that the visual axis here is straight, but because in this position this eye should be abducting, so it is this visual axis is abnormally convergent to the supposed normal direction of visual axis here. So again, this eye should be abducting like this. This is the normal visual axis here, but since the visual axis is like this, so it is relatively convergent. So in this position, in this gaze, the left eye is the normal aligned eye on the fixating target, and the right eye is the esotropic eye. And this applies also to the levo version, who's looking to the left eye. Here the right eye is the fixating eye, the normal aligned visual axis here, but this is the abnormal visual axis convergent, because it should be like parallel to the other, or like abducted. Sometimes you may find this expression that amblyopia is a bit of a combined exclusion and inclusion. What does this mean? So you have to exclude any organic lesions that should be treated first, or organic lesions that actually is responsible for this diminution of vision. And inclusion, there must be risk factor for amblyopia. There must be some refractive error, for example, or cataract, or something early in life that causes or that caused this amblyopia. So it is a combination of excluding any structural abnormality, eliminating this structural abnormality, and there must be, in order to diagnose amblyopia, a form of amblyopia, an etiological factor for amblyopia. All right. I wonder how do you mention the diagnosis for your patients? You have to know the translation of amblyopia in your own language. So in my language, we don't say lazy eye. We say it in the form of functional lazy eye. And you have to mention the cause, due to what? Due to anisotropia, for example, or not. So this is usually the form of the diagnosis you will be given to you give it to the parents or the patient. By the way, lazy eye is a non-medical term and non-specific term because in some articles, especially on the internet, sometimes they use it for strabismus. So sometimes they use the term lazy eye for squint. So it is non-specific, non-medical. However, we say to the patient, when we have an amblyopia, we say this is a lazy eye. This is a functional lazy eye. Another point here, we will repeat it in the diagnosis as well. If we have a best corrected visual acuity of 660, what is the grade of amblyopia? So whenever you come across grading of something, you have to pay attention to this title, to this heading, because not all the cases are the same. And if you check the amblyopia studies, you have to check the inclusion criteria. Are they do this research on mild amblyopia or moderate or severe? So if we have a best corrected visual acuity, suppose of 6/60, is it a mild or moderate or severe amblyopia? So excellent, Dr. Navid, Dr. Kirsan, this is severe, and the classifications comes from Pediatric Eye Disease Investigator Group in 2003. They classify the amblyopia into mild, moderate, severe. So mild from, of course, there is nothing called the 20/20 because 20/20 is normal visual acuity. So we have from 20/25 to 20/40. This is mild. Moderate, worse than 20/40 to 20/100, and worse than this is severe. So 660 actually lies here, 20/200, so it's severe. If we come across a severe amblyopia, you have to vigorously treat it very well. So again, you have to know, sometimes we have a printout of this chart in our clinics, the convergent chart. So you can make a highlight in colors as I did here. So mild here, moderate and severe, in different notation. So currently we are using a decimal notation, but we used to, when I was a resident, to speak like using the Snellen fraction, like 6/60, for example. The most accurate, is logmar, so you have to pay attention to the correlation. And actually, this is one of the most commonly asked MCQ questions in like ISO first part. They are testing your knowledge about the conversion. And pay attention that the logmar there is 0, so 0 correlates with 6 vision, but in decimal notation it's 1. And in logmar we have minus numbers and plus numbers. So try to familiarize yourself how to convert from one notation to the other. So for example, if we have like that 20/100 here, so in your mind 100 is 20 multiplied by 5, so you have to multiply 6 by 5, so we have 630, and so on. Now the next point is the etiology. We will get an overview about the etiology. In some books you may find the title or the heading of etiology, or amblyogenic factors, or forms of amblyopia, or types, or classifications. All are the same. Can you mention the etiological factors for amblyopia? What are the causes of amblyopia? So Dr. Kirsana, can you unmute yourself and say it?
Yes, ma'am. Actually, there are 5 causes. It can be either because of strabismic amblyopia, or it can be because of stimulus deprivation amblyopia. It can be because of anisometropic or high ametropic. Um, what is the last one? I forgot.
You mentioned 3 now. You mentioned refractive, strabismus, and deprivation amblyopia. So you mentioned 3.
A meridional
So it
amblyopia.
belongs to refractive. This is an excellent answer, by the way. But here an advice. Whenever an examiner asks you a question, don't rush and mention a number. So you start your answer by mentioning there is 5.
Yeah.
So the
Yeah.
examiner is counting on you. Start to count. What's 1, what's 2, and what's 3.
Okay.
So you may put yourself in troubles. Thank you, Dr. Kirsan.
Okay.
So she mentioned refractive. So under the heading of refractive, you will add more details in the second part about the refractive. You can mention isometropia, or bilateral high ametropia, or meridional due to astigmatism. There is some subdivision under this heading. And she mentioned strabismic. And as you see here, the refractive considered to be the most common form of amblyopia. And again, she mentioned the last one was stimulus deprivation amblyopia, like congenital cataract. But as you see here, the symbol of a hand, so there must be 5 causes. So can we add other than these 3 causes? So there is something called reverse amblyopia. So we don't use consecutive. We usually use consecutive with ocular misalignment, like consecutive esotropia, exotropia. I don't know if you find this term in a book or something, but we use the term reverse. Suppose you are treating the right eye for amblyopia by patching, and suppose you are doing a full-time patch, for example. You belong to this school, and there is a missing follow-up visits, and you in the next follow-up you will find that the amblyopia developed in the other eye, the fellow eye, the previously normal eye. So this is in short the meaning of reverse amblyopia. All right. Still there is another cause, and in my view this is the most important one. Actually, I don't expect that someone will say it, although I always say it in many topics. So you may find the combined, and this is, I think, for my view, and in my humble view, it is the most common, because you may have a case of strabismus and refractive error. You may have a cataract, congenital cataract with refractive error. So that's why I wrote it in a biggest tab, or the biggest highlight, because don't forget there is a mixed pathology. So this is my way of categorization, and so don't forget the combined cause. So Dr. Kirsana mentioned anisometropia, and of course this is for unilateral amblyopia, and she mentioned high bilateral refractive error, or high bilateral ametropia, and this of course causing bilateral amblyopia. There is another term, more professional term. There is a more professional term for bilateral high ametropia. I said professional because it means that you are reading a lot, not only your standard book, but you are reading also the articles. Let's see. So this the other term for bilateral high ametropic amblyopia is isoametropic. And don't forget the A here. Don't say isometropic, so isoametropic. Alright? So pay attention to this term, because I'm gonna ask you this term next week, inshallah. As I mentioned, the uncorrected refractive errors are considered to be the most common form of amblyopia. Regarding the form deprivation or stimulus deprivation amblyopia, there are too many terms for this form of amblyopia, and there is a Latin term you may find in old books like amblyopia exynopsia. It could be something external, like in the eyelid, like congenital ptosis, as in this photo. Or it could be, this is the most common causes for form deprivation amblyopia, or it could be media opacities. This is just examples. It could be cataract, corneal opacity, or vitreous hemorrhage. And this is just an overview, and as I mentioned, and we will add more details in the next part. Regarding the strabismic amblyopia, always remember this kind of mnemonics, mnemonic S for S. So can you guess what S for S? This is a kind of rhyme here. Can you guess what's S for S? So S for strabismics. And how about the second S? No, don't confuse stimulus, because stimulus may confuse you with the stimulus deprivation amblyopia. Not sensory, not single. So remember, strabismus cause amblyopia if it is unilateral, right? And there is some form of visual adaptation if we have a unilateral strabismus in a child. So this is only in a child. So if you have a child with right esotropia, for example, there is some form of visual adaptation in the right eye that leads to amblyopia. Excellent. So Dr. Kirsana, secondary, it is a logical answer, but the correct answer here is suppression. So here in strabismic amblyopia and in unilateral constant strabismus, there is suppression to this strabismic eye to avoid what? And again, this is in childhood. To avoid what? Here, can you fill the gap? Diplopia, excellent. And sometimes fill in the gaps incorporate more than one word. Excellent, Dr. Kirsana and Dr. Sana and all others. So to avoid diplopia and confusion. Excellent. So can you define a diplopia? So this is like a pop-up question. So imagine now you are in the oral exam, especially in national exam, and someone asks you define diplopia. So you already know diplopia, but can you now articulate how can we define diplopia? This is another example that you already know what is diplopia, you already know what is confusion, but can you deliver a full answer to define these terms? So you have to practice. Even myself, I didn't practice to give you an answer now, but I made this diagram. So sometimes one picture worse than 1,000 words. So here is this is a normal ocular alignment, right? Normal ocular alignment, looking at a near target. So we have a near target here, this green star, and the visual axes here are converging and intersect on the object of fixation, and the image of the star falls on the fovea of each eye, and we have a single binocular vision. All right. Suppose for some reason the right eye abnormally goes in, and as you know, the globe is a globe, the eyeball is a globe, like a ball. So if the anterior segment moves in, the posterior segment moves out. All right. So now look at the right side. So let's draw the abnormal. So we have now abnormally misaligned right eye, and let's draw the abnormal visual axis. So this is the abnormal visual axis. It is converging. So optically, when we teach optics, we usually say this in convergent squint. In esotropia, the visual axis is converging. All right. So back again to the target of fixation here. The star is falling in the fovea here. And how about the other eye? It falls nasal to the fovea. So in convergent squint, the target of fixation is falling nasal to the fovea. And we know there is something called projection in the field. So whenever there is something nasal to the fovea, it projects temporal. And this is a definition by animation. This is how we define diplopia. And to be more specific, this is uncrossed diplopia, because we have the diplopic image here is on the same side of the misaligned eye, and we have esotropia, and you know that esotropia causes uncrossed diplopia. So during childhood, the child suppresses this area, and this is called peripheral suppression. So most kids couldn't appreciate the feeling of diplopia because their visual system is still immature, and they adapt by suppressing this point. All right. And this is a diplopia. How about confusion? Here the fovea of this abnormally misaligned eye actually is looking at another object. So we have here two different objects stimulating fovea here and the fovea here, and this is called confusion. Two different objects simultaneously stimulate corresponding points here, which are the foveas of both eyes. I hope it's clear now. So strabismus is fun, and the main issue regarding the strabismus, you have to study it piece by piece and start by the basics always. Regarding the combined or the mixed amblyopia, I already mentioned an example like cataract with refractive error, strabismus with refractive error. So you have to mention combined or mixed amblyopia as one of the causes or one of the forms of amblyopia. So we are about to finalize our presentation, and this is the quiz time. Now the first quiz here, we have three. You have to read it by yourself. This is like a mock exam. And again, another emoji. We have a countdown. Now you can read the question and be ready for the next slide, which is the quiz. Okay, let's read it. The first one. Which case is the least likely to have form deprivation amblyopia due to cataract? So try to pay attention to every specific word here. So I'm asking about the least likely, not the most likely. And I am asking specifically about the form deprivation amblyopia due to cataract. I want to hear your voice. So this is a kind of challenge here, because you can all now unmute your mics. If you are sitting in a quiet room, you can unmute your mic, please, and we will see who will answer first. Ready, steady, go.
Two. Number 2 to the right.
I think the fourth picture, ma'am.
Third picture.
Okay.
I would like to thank all who unmute your mics and answer. Dr. Hala, I think you mentioned an answer, and Dr. Kirsana and Dr. Sana.
Yeah.
Yes, and I'm sorry I didn't put a number.
The upper right.
So Dr. Hala said the upper right, and Dr. Kirsana said the fourth, this one, right? Dr. Kirsana, you mentioned this one?
No, the last one.
This
The
one?
last one, ma'am. Yeah, this one.
Okay.
Fourth.
And this
Yeah.
is fourth. And Dr. Sana mentioned? Dr. Sana, you answered that.
The third one. Third one.
This one.
That I felt it is mittened of dot.
This one. Nice, we got different answers. So Dr. Hala said the one in pink, right? Dr. Hala, she mentioned the one in pink. And Dr. Kirsana mentioned the one in yellow. And Dr. Sana mentioned the one in green. Shall I ask you to justify your answer? So I will start by Dr. Hala because she was the first one to answer. So can you justify why you choose the one in pink?
This a child still can't see. It is not covering the nodal point. It's paracentral.
All right. And Dr. Kirsana?
Ma'am, actually, I thought that's the only condition where both the eyes are being involved. In all the other pictures, you've shown only one eye. So that was the reason I selected this because the suppression will be monocular in all the other cases. In this case, it cannot be like that. That's why.
Okay, and Dr. Sana?
I felt that the picture shows the mittened of dot and it won't affect the visual acuity of the patient. So that's the one which can have the least chances of amblyopia.
Okay, thank you. All right, so let's check together, and I want to make sure that I can convince you because actually this is my inventing question. So I'm just try to translate some information in the form of photos. So how about this one in olive color here? This is a significant, visually significant cataract because here the pupil is already dilated and the opacity is filling all over the pupil. So this is a visually significant and it's unilateral, and this is an urgent case for interference, maybe 2 weeks old. And Dr. Kirsana, I think this one in yellow is visually significant, but it is yes, it is bilateral, but still should be scheduled for surgery after 1 month. So the priority comes to this one in olive green, and the next list we will have to operate this one because it is still visually significant. And my question was about the least likely. So the least likely means the least visually affecting. Regarding this one, Dr. Hala, so to decide central, I think it's almost central, but we can judge more about the center or not from the front view, like anterior-posterior, not a sagittal view. And even if you feel that it is a little bit eccentric, sometimes the area surrounding the cataract, there is some opacities and it causes much refractive error here, like astigmatism. Especially this case has also posterior lenticonus. So this is actually we don't measure it, but it is we consider it as visually significant because it is almost in the nodal points. And
but the reflex is central. This light reflex is central and it is paracentral to the reflex.
Actually, the child is not looking to the camera, so you can get a decentered light reflex or decentered Hirschberg test if the patient is not looking to the camera. So this misleading corneal reflection here because the patient actually is abducting, the child is abducting his eyes. But so even if you look at the cornea, it's not circular because it's like eccentric viewing, like off-center, like profile photographing of the picture. So I am with Dr. Sana because this one is the least visually significant and least likely to affect the vision, and the least risk for inducing amblyopia. Still, all cases could develop amblyopia for sure, even this one, because it could be another factor like refractive error, not only the opacity. So the correct answer here is this one in green, the anterior polar, or we can say Mittendorf cataract. I hope I convinced you, Dr. Hala and Dr. Kirsan. So again, Dr. Hala, if you are confused between anterior polar and posterior polar, you have to choose the anterior polar as the least factor for amblyopia, or least affection of vision. The next one here, so you can read it by yourself. All right? Ready, steady. I will shift the slide now.
The yellow one.
Green one, ma'am. First, second, third one.
Green one. Third one, green one.
First one in olive, because the left eye has ptosis and esotropia both.
But it looks pseudo.
Yes, it's pseudo. Yeah, it's pseudo. So thank you for your participation. It's my honor. So here, Dr. Hala mentioned this one. So by the way, this is a case of what? Marcus gun, jaw winking ptosis. So we have a ptosis here. But as you see, you can still see the corneal reflection. So it is not covering the pupillary reflex here. And with jaw movement to the contralateral side, there is lid retraction. And what's beautiful about Marcus gun, we have both conditions. We have ptosis and we have retraction, but of course not simultaneous. So retraction.
The least Marcus gun ptosis will have the least amblyopia.
Yes, thank you, Dr.
Because the palpebral aperture opens widely.
Yes, so the eye opens or the eyelids retract, and even without retraction during the ptosis, this ptosis not covering the corneal reflection. So my question was about the most likely, not the least likely. So, and here this child, despite the fact that she or he has severe ptosis, but the compensatory head posture here, I think, is good for her because she can see by this chin up. And this one in olive green here, still we can appreciate the corneal reflection here. But what about this one? Here we can't see the corneal reflection, and we obstructing the visual axis, and it is unilateral. And always unilateral is more dangerous than bilateral visual deprivation. So the correct answer here is this one. All right. The last one, this is about the most likely due to strabismus. So, Dr. Navid, I want to hear your voice now. Unfortunately, it is about strabismus. I don't know if you like it or not, but as I mentioned yesterday, it is a bitter pill to swallow, even if you don't like it. And I use the countdown with the music to make some distraction. So I'm trying to distract you. So don't be bothered. Which case is the most likely to have strabismic amblyopia?
And the third one, dark green.
Okay, thank you, Dr. Naveen. Thank you, Dr. Kirsana. And only two answered. So, Dr. Kirsana, you mean this one? Right? And Dr. Naveed said again this one, the green. And Dr. Sana mentioned the yellow. Time is not enough. So, that's sometimes in the courses, in like preparation courses before the exam, they teach you how to answer rapidly, to think rapidly, because you know in the viva or in the clinical station, time is limited. You have to think and answer rapidly. All right. Let's see. I think this would be the last slide, because we already spent 1.5 hours here. So I don't want to overwhelm you, especially when it comes to strabismus. So let's see one by one. Here in this olive green, in the first photo here, the left eye, so be concentrated because I'm not repeating the words. So the left eye is isotropic. This is the normal fixating eye, the right eye, and the left eye is the convergent, is the isotropic. And in the next photo here, we did cover test, or there is a cover test. So we are covering the fixating eye. The child takes the fixation. So this eye takes the fixation, and that's good. It has the ability to take the fixation. Because now the brain sending impulses to allow the eye to move out and to take the fixation. But as you know, since this eye is the fixating eye now, the right eye under the cover by Hering's law is isotropic, because this eye moved out to take the fixation by the lateral rectus here, lateral rectus. On the same time, the brain send impulses to the medial rectus here, so the right eye under the cover is isotropic. The third photo here, once the examiner removed the cover, the occluder, the right eye still shows the isotropia which was under the cover, and the left eye keeps the fixation. So this, we call it alternating isotropia. So this is a case of alternating isotropia. It means that the squint can be evident on the left eye or the right eye. And alternating strabismus poses little risk for amblyopia. We expect that we have equal visual acuity. So this is not the correct answer for my question. How about this one in green? In the first photo, the child, the girl here, looks orthotropic, means the corneal reflection by Hirschberg test, for example. By Hirschberg, the corneal reflection is in the center, so it seems orthotropic. Yes, Dr. Sana and Dr. Naveed. This is, but sometimes, especially if she is inattentive or under fatigue or looking at far object, this is looking at near, but this is looking at far, she develops exotropia. So we have periods of orthotropia and periods of manifest squint. So this is called intermittent exotropia. Again, less risk for amblyopia. Okay, so Naveed, doctor said here intermittent exotropia doesn't have amblyopia. This is not the rule, because sometimes we have intermittent exotropia, but the period or the time for manifest is more than the periods of phoric component. So if you have the tropic component is more happens more than the phoria, so most of the time she is tropic, she will develop amblyopia. So there is no rule, so we have to check the visual acuity. But again, intermittent exotropia is less risk for amblyopia if you compare it to the unilateral constant strabismus. And how about the one in pink? So the one in pink here, the right eye is isotropic. So the examiner did the cover test. So the right eye takes the fixation, and we already know that the left eye under the cover is isotropic. But once the examiner removes the cover, there is a shift. There is again the right eye shows the isotropia, and left eye return to the fixating pattern. So the left eye is always the fixating eye. It drifts only under the cover when the right eye is fixating. But once we remove the cover, once both eyes are open, the squint is almost always manifest on the right eye. So this is a case of unilateral esotropia constant. And this is the correct answer. This is the most likely to have or to develop amblyopia, because here the squint is all the time appears on the right eye or in the right eye. Dr. Sana, what do you mean by right latent esophoria? I don't. There is nothing called right latent esophoria. So you can't say side for phoric horizontal squint like esophoria or exophoria. You can't say right or left. So esophoria or exophoria is something means tendency of either eye. So you can't say the laterality, something right or left for phoric strabismus. We say it right or left or right or left or alternating for tropic squint, not for phoric squint. Again, you can say latent with esophoria, because esophoria by itself means latent convergent squint. You're welcome. How about the last one, and this is the most difficult one. If you look closely at this picture or at this photo, you will find that the Hirschberg test here is decentered nasally. So we can't expect that we have a squint in both eyes. So the Hirschberg here is decentered nasally, in both eyes. So we never get something called exotropia in both eyes unless we have a restrictive or paralytic component. That's why I wrote here free ocular motility. The patient has, this boy has free ocular motility. So when it comes to concomitant strabismus with free ocular motility, strabismus should be evident in only one eye. But here there is an XT in both eyes. Actually, this is a pseudo exotropia, pseudo divergent squint due to abnormalities in the angle kappa. To make it short, there is something called angle kappa. Normally, the normal angle kappa causes central corneal reflection or slightly nasally decentered. But here it is too much decentered nasally because the angle kappa here is abnormally large. So if we have an abnormally large angle kappa, the Hirschberg is decentered too much nasally, giving you a false pseudo divergent squint. So actually this is not a case of true squint, this is a pseudo exotropia. Okay, and you have to know what are the causes of large angle kappa, like temporal dragging of the macula, like in ROP, or high axial hypermetropia. All right, I think this is too much for you, so I will skip some slides here. See you next time with the second part, and it will inshallah on the 7th at usual timing, 6 o'clock India time. And again, my request, attention and be watchful whenever have a case of amblyopia in your clinic in the coming days. Please post it in the WhatsApp to discuss in the last part of our presentation. I will bring some of my cases, but I want you to, again, to participate in the presentation. I don't know if I can ask you this, to request you to make like a 2 to 5 minute presentation about each of the etiological factor of amblyopia. So can I assign you, or it will be too much for you? So I want to start the next presentation by having your presentations. So I can assign you now, and if you agree, you can do it. If you don't agree, you can ignore it. So here we have Dr. Hala in the order. So kindly, Dr. Hala, you can do a presentation about the strabismic amblyopia. Teach us a little bit about the strabismic amblyopia as an etiological factor. I shall write your name. And Dr. Kirsana for stimulus deprivation amblyopia. And Dr. Navid, I think all like refractive, so luckily you got the refractive. Dr. Navid, sorry. And because combined and reverse amblyopia the last two, so I shall write Dr. Sana in both. So again, this is not an obligation, this is something optional, and yeah, I have now come to the end of this presentation. Stay active, stay alive, and study attentively. And thank you so much for attending this meeting until its very end. And thank you for your participation. And see you next time. Bye bye.